Jerry Powell podcast is brought to you by Archstone Foundation, preparing society and meeting the needs of an aging population. And now, here are your hosts.
Welcome to the Jerry Powell podcast. This is Eric Quidera.
This is Alex Smith.
And Alex, who do we have on our virtual studio?
In our virtual studio from Los Angeles, we have Adela Greeley, who's a hospitalist at the West Los Angeles VA and is affiliated with the UCLA School of Medicine. Welcome to the Jerry Powell podcast, Adela.
Oh, thank you for having us.
And we have Paul Shekelle, who is a general internist, also at the West LA VA, and worked with our chair of medicine, Bob Wachter, on the patient safety report, of which the paper we're going to talk about today is the descendant, about sitters and patient safety strategy to reduce hospital falls, published in Annals of Internal Medicine. Welcome to the Jerry Powell podcast, Paul.
Thank you.
We are very excited. We're going to be talking all about sitters or CPAs or whatever you call them in your hospitals, and do they help with falls? But before we go into that topic, we always ask for a song request. Do you have a song request for Alex?
Yes, we do. Fall on Me by REM.
And why this song?
Well, one, I love REM, and two, whenever I'm admitting a patient, I think I always say, oh, please don't fall on my watch. Please don't fall on me.
Please don't fall on me. That's great. There's a problem, feathers, iron, bargain buildings, weights and pulleys. Feathers hit the ground before the weight can hit the air. Buy the sky and sell the sky and tell the sky and sell the sky. Don't fall on me, fall on me, fall on me. Oh, poor REM. I butchered that. Well,
It was
sorry, Michael Stipe. I didn't have a full band behind me, and Eric didn't learn the backup part.
Oh, yeah, I was supposed to learn the backup part. You told me I had to learn the backup part. I totally forgot about that.
Well, hopefully somebody else will request REM in the future, and I'll have another chance to do better justice to that terrific.
I will have another chance to forget that I was supposed to do
terrific
something.
band. Yes.
So we're going to be talking about your Annals of Internal Medicine paper, Sitters as a Patient Safety Strategy to Reduce Hospital Falls. We'll have a link to it on our Jerry Powell website. But before we talk in the paper, why did you get interested in this subject?
So this was actually a subject that was chosen by central office at the VA to look at the effectiveness of sitters on falls. And so Paul was the lead in this, and then I was asked as a hospitalist who has used sitters a lot in my practice, whether or not I would want to join the group to look at the evidence behind using sitters for falls.
Yeah, let me expand on that just a little bit. So what we are one of 4 centers that the VA supports to specifically review the evidence on things that central office wants reviewed on. And so these are things that usually come up from the field, questions that field practitioners have that for which the VA wants to make some kind of policy decision, but first they want an evidence review. And so this one had enough support from VA field practitioners to say, hey, let's find out what the evidence of this, about this strategy looks like so that we can decide what we should do as a system about it.
I'm sure many of us who practice in hospitals, as we do, are very familiar with the concept of a sitter, and intuitively, it makes sense. And I wonder if you could talk a little bit more about the rationale behind sitters and why they, if you know something about why they were instituted in the first place.
We didn't find a lot of background history as to when exactly the first sitter was used or how it came about. And I think, as you said, it is just intuitive that you would think if you have a patient who might be at risk of falling, having someone sitting there at the bedside would be the best way to prevent said patient from falling. But I don't actually know how long ago.
I started in 1982. They were already being used in 1982. So I think that they like the proto-sitter use is lost in time.
Now, there's some things that we do that may not have evidence, and they're really bad for patients. But what's the harm of just having like a sitter, somebody hanging out with someone, making sure that they don't fall?
Well, there's a couple of potential harms, okay? The first one is that these things are really expensive. And so if a hospital is having to spend X amount of resources on sitters, okay, well, if they offer a benefit, great, okay? But if they're not offering a benefit, then the harm is opportunity cost for that money to be spent on something else, all right? And then the second harm, which was not systematically reviewed or systematically reported on, in that there's no systemic evidence, but we certainly came up anecdotal evidence, is that the sitter themselves can be harmed by the patient. And so there is an anecdotal body of evidence about things that happen to sitters from patients who are, demented or aggressive or whatever it is. So it's not a zero risk thing.
And are most sitters, do you think, to try to prevent falls, is that what they're used for probably most commonly? I know there's potentially other reasons that they may be used.
So in the studies that we found, the reasons for sitters were falls, elopement, and then also suicide risk. And when they were being used for elopement or suicide risk, those patients were excluded from the study. So those are the three main reasons that we see sitters being used most often.
Yeah, and everything that we talk about in sitters going forward, it doesn't have to do with patients that are having sitters because of suicide or because of wandering. Okay, That's a separate kettle of fish that we're not dealing with.
Mm-hmm. Can we talk about terminology before we dive into the article a little bit? What is the best word for sitters? I know at our hospital we've started to call them CPAs for, what is that, Certified Patient Assistant? Is it okay to use the word sitter? It's certainly the term that's most familiar to most clinicians.
Yeah, so we came across in our review that some places call them sitters, some places call them safety attendants, some places would call them one-to-one specialing, and so we didn't find a one term that everybody uses, or one term that anybody found to be offensive if it were used.
Yeah, but we use the term sitters in the article because that seems to be the most commonly used term. But something that you brought up is a really good point. You use the word certified, all right? So that begs the question, so like, what are the qualifications to be a sitter? And at least in the articles that we looked at, they never specified exactly what you had to do to be a sitter. And at least in a couple of them, they were like volunteers, all right? But it's conceivable that a different kind of position, a different kind of certification might result in different kinds of outcomes than what we actually found.
Mm-hmm. And I wonder about if is there a pejorative sense of the word sitter, like babysitter? Is it infantilizing patients to some extent to use that term, or the role of the person who is watching them?
I think the reason we changed it from sitters to CPAs is we actually don't want them just to sit. Like, we want them to do things to help get this person activated rather than just looking at their phone and sitting there
or watching the TV. Or watching, general experience is they have the TV turned towards them, and then I go in the room and turn off the TV many times during the day.
Yes.
Well, yeah, I mean, that's a good point. I mean, what are they supposed to do? I mean, this gets to the same issue that in my previous answers, is that at least in the articles that we looked at, a description of what this intervention actually was usually nothing more than sitters. So what they were told to do, what their job was, I mean, presumably they're told, don't let the patient fall. Don't let them, walk out and walk around the nursing station. But what the actual responsibilities are, it's not detailed in any of these articles.
So let's talk about your article. What if you can just summarize what you did in your article?
So it was a systematic review that we did of the literature looking at the effectiveness of sitters on falls. So we looked through, how many titles was it that we looked through?
A very large number.
And, looked for anything where it was either sitters as the primary intervention to prevent falls or alternatives to sitters looking at falls specifically. And we found 2 articles that purely used sitters in comparison to usual care in the hospital, and all the rest of our articles were alternatives to sitters. And what we found was that there is very little published studies that actually look at sitters versus no sitters, that the majority were looking at sitters versus alternatives to sitters. And of those, the alternative to sitters, the video monitoring was found to have the best and most consistent evidence that not only did it not worsen fall rates in the hospital, but it also decreased the sitter use significantly in the hospitals.
Yeah, so just a couple follow-ups there. I think the distribution of articles that we found tells you how this is perceived in the U.S. healthcare climate. Sitters are taken as a sort of a prima facie, on the face of it, good, right? It's a good thing. And so nobody's trying to figure out whether sitters reduce falls. They're all trying to figure out how to decrease the cost of this. And because every article was about decreasing the cost of sitters. Sitters cost too much money. We have to figure out something that we can do differently. Ergo, we're going to try whatever these various alternatives are and compare them to what sitters achieved.
And I find it fascinating that to learn about alternatives to sitters. Could you go into a little bit more detail about what are these alternatives? What else can we do other than usual care?
So we kind of put it into 4 different categories. So one category, of course, was the video monitoring. Another category was creation of these constant observation units where they would cluster, 4 patients together into a room where they had one person directly observing them. Another intervention that was used was doing nursing assessment. So it was basically taking the ordering away from the physicians. The physicians wouldn't be the ones who would order the sitters. It would be through protocols that the nurses would use to determine who best needed a sitter. And then the 4th was a miscellaneous category where a lot of these studies would look at the need for sitters in their particular healthcare system. They would look at alternatives such as bed alarms. They would look at other alternatives that they could use. They would benchmark with other hospitals and put in place interventions to see what would happen to their fall rates while they were trying to decrease their sitter usage.
Yeah, so, and just to expand on that, so this is one of the challenges with doing this kind of a systematic review is it's not like a systematic review of, which drugs for hypertension also have the best cardiac effects? Right. So we're going to compare beta blockers, we're going to compare calcium channel blockers, we're going to have diuretics, where things are fairly homogeneous in those groups, right? Almost all these things are kind of a one-off idea that somebody had to reduce sitter use, and then we had to aggregate them in groups that made the most clinical sense to us, so that anything that had a video in it went into the video category, even if they also had other things. If they built a special room but didn't have a video, it went into that category. Anyway, so it's coming up with the categories. Within those categories, it's still, fairly heterogeneous.
I wonder if you could say a little bit more about video monitoring. I don't know if either of you have clinical experience with this or have seen examples or visited hospitals that have this. I'm curious what this looks like and how similar it is to, say, ICU remote monitoring overnight. With an ICU clinician sitting in one room monitoring multiple ICUs at the same time.
Yeah, I don't have any personal experience with video monitoring. I just learned about it through reading all of these studies and how they were done, but I've never had a patient on video monitoring per se for falls.
Yeah, I mean, my sense from reading the articles is that it's not a remote thing, so it's not like there's a guy sitting in Nevada who's monitoring, our care here in Los Angeles. But it sounded more like it's somebody at the nursing station, and they might have 6 monitors, okay? And so there's 6 patients, so they have 6 monitored patient rooms. And there's quite a bit in the articles about, like, what kind of monitor and how it's set up and how they get trained and all this other kind of stuff. But then this one person monitoring these 6 monitors is taking the place of 6. FTE sitting in each of those rooms. Okay, so that's sort of how the idea is. But it's basically like closed-circuit TV monitoring. Some of them also have microphones so that you can actually hear what's going on, and some don't.
So you said that there may be some evidence for that type of video monitoring?
Yes, so we found in all of the studies that we reviewed, the results were pretty consistent that the fall rates either stayed the same at the hospitals. Some of them, the fall rates actually improved with the video monitoring, and all of them reported significant decrease in the amount of sitter usage that they had. So we rated it as moderate quality evidence for the use of video monitoring.
Now, one of our very first podcasts that we ever done was on bed alarms, reviewing one article that came out a couple of years ago on the use of bed alarms. Was that in Annals too? I think it may have been Annals.
Maybe.
What are your thoughts on bed alarms? Did you look at them?
Did we look specifically at bed alarms, or were they?
Yeah, compared to sitter use, or was there any studies that you found comparing those?
So they came up in some of the studies as an alternative to the use of sitters.
Yeah, but not by themselves.
But not by themselves. It was kind of a conjunction, that one of the interventions that they would employ would be using the bed alarm. But there was nothing that was specifically bed alarm versus sitter.
Yeah, so these alternatives, often they're almost always multi-component. So it's like we put a wristband on them, we put a sign up saying they're a fall risk, we put a video monitor in, and Adela put together a really great table that's in the article that shows what all the various co-interventions are. And so that's really worth looking at. But it shouldn't be assumed that these are simple, beta blocker versus, calcium channel blocker. They're not like that.
Mm-hmm. So I want to get back to your main findings here, that 2 studies comparing sitters to usual care, and you found very low certainty evidence of adding sitters reducing falls. And I want to ask, you've probably heard this phrase, absence of evidence is not evidence of absence. I think I'm not sure I have that right. Does that sound right?
Yeah, no, that's the way it goes, yeah.
So to what extent is this a message that we have enough evidence here to say that there's just a tiny minuscule, poor quality signal that sitters may reduce falls? And to what extent do we say that we just don't have enough evidence really to make a call on this one way or the other at this time, and we need better studies?
So, I think it is that we really do need better studies. The 2 studies that came out, as we said, they were, first of all, they were both from Australia, and the fall rates there are 5 times, their baseline fall rates are 5 times what they are here in the United States. And they were volunteers that were used. They weren't there 24 hours a day. And so, what would be wonderful is if we could get, a pure randomized controlled trial of sitters versus usual care. But I don't know if that's actually possible here in the United States, because sitters are such an ingrained part of what our usual care is now in the hospital, that as soon as we take away a sitter, I think we start adding or doing things to try to prevent them from falling. So I don't know if we'd ever get the pure sitter versus usual care.
Yeah, I mean, you make a great point that is the absence of evidence here enough to say that the things don't work. And we make the point in our Annals article that we don't think that's the case, okay? I mean, the rationale is so compelling that 2 studies that reached conflicting conclusions aren't enough to jettison the whole thing over the side. However, I would say that the ease with which studies have been able to take them away and put in alternatives suggests that it's not going to be a ginormous effect, okay? Because it's pretty hard to take away something that's a ginormous effect unless you are substituting something that has an equally ginormous effect and not see an adverse consequence of it. And so a lot of these studies that did this, we did this, they didn't all reach conclusions that showed that they were able to reduce sitter use much, but they didn't really increase the fall rates. Okay, so my guess is it's not a ginormous effect.
Yeah, I mean, I find it interesting because I also think about the use of sitters. Like, individuals get sitters and they got to have them discharged generally within 24 hours of discharge if they're going to a nursing home, because no nursing home wants to take a patient with a sitter. So magically, they're not falling in those 24 hours often. So it would be interesting to do a study like what the time points that sitters are discontinued and seeing fall rates both pre and post it. And magically, I think that 24 hours before discharge, magically these sitters disappear.
Right. And the nurses know this. I mean, they know, oh, we're trying to get this patient out. So the nurse is more attentive. They have the patient come out in the hallway and sit there,
Right. So they're doing their own alternatives to sitters. Are they moving them closer to the nurse's station to keep an eye on them? Are they, wheeling them out into the hallway when they're eating meals? Are they, making sure they have better sleep hygiene or something to prevent them from trying to get up out of bed?
Those are great points, and I want to make sure that your listeners understand that one of the take-home messages from our article isn't go out there and blow $1 million into a video monitoring setup, even though that is the thing that had the most number of published studies. There are definitely good low-tech examples of getting in and doing all these kinds of little things, and we talk about one article in particular that we reviewed in detail, which showed pretty dramatic changes and in decreasing the need for sitters without changing fall rate. And it's all that kind of stuff you were just describing.
And do you remember what are some of the things they did in that article to help decrease fall rates, decrease sitter use?
That was the Adams article. That's what they did. A lot of benchmarking. I think they used chair alarms, bed alarms. I think they revamped their ordering system for sitters where you had to justify why you were having a sitter. So they did all sorts of little things, and they added every little step over time. So it wasn't just one big bundle. So they would look at an intervention. They would see if the sitter rates were going in the right direction, if the fall rates were going in the right direction, and then they would recalibrate and add another intervention. And it was a nicely done.
Yeah. And so the point there is not really, at least from my perspective as a quality improvement patient safety initiative kind of guys, it's not exactly which things they picked. It's how they got to those things. So they did a lot of work talking with frontline staff, trying to figure out why are people falling? Okay, what can we do to change this? And so they vetted through a whole bunch of different things. They had a multidisciplinary team working with it. And then they started adding these things iteratively, testing each one out until they came up with what they finally thought was their most effective package. And that package may look different at your hospital than our hospital. It may look different at a third hospital. But it's the process of how they got there that shows what I think can be done for a lot of different types of safety and quality issues.
Mm-hmm. I have two more questions. So first relates back to that first Jerry Powell podcast about bed alarms. And Eric and Ken Kavinsky came up with this notion that we should have the anti-bed alarm.
Oh yeah, that was a good one.
Right, that if you're in bed for some period of time without getting out of bed, then the bed alarm goes off, telling you it's time to get out of bed. Right.
Yeah.
And I wonder if there's some similar sort of spin it on its head notion around sitters. Can we reconceptualize them as people who are doing all of these important investigative things like fall investigator or anti-fall investigator? I don't know, to sort of empower them or empower the nurses or empower the team taking care of them to prevent falls in all of these different ways that you mentioned, Paul.
That's a great suggestion. So I don't know, at our hospital, we have something called a wound care team. And, so you admit the patient for heart failure. But if they got, the wound care team comes around and looks at everybody, tries to assess whether they're at risk for pressures and ulcers. If they see anything that's going on, they'll give you a bunch of recs, right? And you can imagine a falls prevention team that comes around and sees everybody over a certain age or everybody who has a certain set of comorbidities and makes those same kind of, detailed person-by-person recs about what you're supposed to do. That, you've got it. That's your idea. Some budding hospitalist researcher out there can take it away.
So, Adela, I got a question for you. You're a hospitalist. You're practicing out there. Are you doing anything different after completing this article and seeing the results?
No, currently we're not. We don't have any alternatives to sitters here. And so, sitters are what we order when there's concern that we're going to have a patient that falls. I hope that, in light of what we've found, it might start some discussions here about the possibility of alternatives to sitters, because as you said, there's always that great debate. When do you stop the sitter so that, you can transition the patient out of the hospital setting? There's always, resources, because a lot of times there's extra nursing has to be called in for these sitters. So I would hope that maybe now it'll be a talking point for, what kind of alternatives might we consider here.
Yeah, that was going to be my similar sort of last point here. Paul, at the beginning of the podcast, you mentioned that sitters have been in existence since at least 1982 when you started clinical practice. That is a
dawn of time.
The dawn of time. That is a long history, and certainly you also, both of you mentioned that this is usual care now. What is it going to take to move the needle here? Is it a randomized trial? What do you envision is the next step?
Yeah, so, my guess is there aren't going to be randomized trials of sitters versus no sitters, because I think it's just going to get, the patient accrual is going to be really hard to do that. I can imagine some cluster randomized things, so like this ward continues to have sitters, and this ward is going to have some alternative or whatever. But the thing that's going to move the needle is money. And so it's like if a hospital's spending X on sitters, it's just a matter of time until that comes into the crosshairs in terms of saying, oh gosh, look, there's this article that was in Annals that showed how people could save money and not change fall rates by doing X, Y, or Z. And every hospital has their own set of things that are cooking, on the front burner. But at some point, this is going to rise up to front burner kind of status, I would suspect, pretty much everywhere.
And Adela, any thoughts from you about next steps that you'd take?
No, I think it's just dialoguing with administration and finding out, is this an important enough topic for them to want to look into alternatives to sitters?
Let's say, because you said the VA central office they're the ones who kind of helped initiate this. Hypothetically, I know you're not speaking for the VA central office, but if you were sitting in that central office, let's say of a different institution, I won't even say the word V something A, what would you do differently if you were now not from a provider perspective, but from a institutional perspective? What would you do differently as a kind of next steps after this article?
I think, looking at fall rates, looking at how much additional nursing is needed for the sitters, and whether or not it would be in the best interest and the safety of the patients to consider alternatives to sitters. Yeah, falls are a, JCHO kind of thing, right? And so, again, every hospital administrator probably has a list this long of the things that he or she's having to deal with. And so there may be other things that's higher up on their priority list. But if fall rates in the hospital are a priority, are high enough for a priority, then I think that you could either look into the video, or if you wanted to go lower tech, you could look into the article. That was Adams, the article by Adams, about how they did it, about this sort of careful little tiny PDSA cycle kind of thing. And you probably have a pretty big impact within. Again, it's not overnight cures, right? This would take 12, 18, 24 months before you finally got to where you were seeing the big effect. Yeah. And the video monitor studies, and it wasn't one of those one size fits all that, you wheel a video camera into the room and it was done. They did everything very systematically, and then they had escalation protocols and training for the people who are going to be looking at the video monitors. What kind of behavior should they be looking for that could possibly lead to a fall, and what would their next steps be? So it's not just a matter of installing video cameras with two-way microphones and you're done.
Yeah, just like any other HIT intervention, there's a lot of other stuff that has to happen.
Great. Anything else you guys want to discuss before we hear a little bit more REM?
No, man, bring on REM. Michael, go for it.
Well, I want to thank both of you for joining us.
Thank you so much, Adela. Thank you so much, Paul. Really appreciate it.
We're going to give Alex another try.
There's a progress we have found, a way to talk around the problem Building towered foresight isn't anything at all. Buy the sky and sell the sky and bleed the sky and tell the sky. Don't fall on me, fall on me, fall on me.
If I had a lighter, I'd be lighting it right now.
That was perfect.
That was slightly better. Well, thank you so much again.
And thank you to all of our listeners for joining us this week. And a big thank you to Archstone Foundation for their support.
And we'll see you next time. Thanks so much. Bye.